Today's presenter for our ECHO is Lisa Weitzman, licensed social worker, independent social worker. Lisa is the WeCare administrator and the manager of business development. She oversees the development of strategic partnerships to drive the delivery of Benjamin Rose Institute care consultation, known as WeCare, because you do, to clients and contracting organizations through Elder Care Services Institute. As a BRI care consultation master trainer, she also supervises the care consultants working directly for ESI. Weitzman joined Benjamin Rose in 2018 as a BRI care consultation consultant and assistant master trainer. She earned her bachelor's degree of Arts in History with a concentration in American Foreign Policy from Yale University, a master's degree in Soviet Studies and International Economics from Johns Hopkins School of Advanced International Studies, and a Master of Science degree in Social Administration from Case Western Reserve University. She currently holds an LISW license and has completed her leadership GIAGA in 2001 and also holds a dementia care specialist certification. She currently serves on the founding board of Courage to Caregivers, on the board of Dancing Classrooms of Northeast Ohio, and as an acting member of the Council on Older Persons and the Cleveland chapter of the Alzheimer's Association. She previously served on the board of the Women's Center of Case Western Reserve and is president of the board of trustees of the Geauga County Library. The case presenter today will be Doug Doyle from Direction Home, Eastern Ohio. So it looks like when we have 30 attendees or more, and we do today, gratefully, will not take a lot of time to take away from our presentation to introduce each other. But please, if you wouldn't mind putting up your face at least on the while we meet, so we can at least see each other. Thanks so much. So, just a few housekeeping items before we begin. Please mute yourself during the presentation. To communicate with the group, use the chat function and share all chats with the entire group. If you're on a phone, use *6 to mute and unmute. And please make sure your name shows on the screen as well as your face. We really are trying to build community here, and doing that, even with our faces, helps do that. During the case presentation, you can unmute to participate in the discussion as you wish. And just so you are aware, today's session is being recorded. Also be aware that the details of the case have been changed to ensure patient privacy. At this point, I'm going to turn things over to Lisa Weitzman to begin the didactic portion of ECHO. Thank you.
Thank you so much, and welcome everybody. So happy that everyone's here to join me. Denise, I think you are very kindly going to be showing the PowerPoint. So as Margie said, our presentation today is an integrated approach to the social determinants of health. And really what it is a deeper dive into how Benjamin Rose Institute on Aging responded to the challenges of COVID-19, what we've learned, and where we need to go from here. Next slide, please. So just a quick overview of who Benjamin Rose is for those of you who may not be familiar with us. As the name would suggest, we are an organization devoted to the care and keeping of older adults and their family caregivers. We are about providing services on the ground, developing innovative solutions through our research department, and then really fostering public conversation, public policy engagement around issues having to deal with aging. We've been a nonprofit organization in the Cleveland area for over 112 years. And we have met those needs through direct practice services, through our senior centers, behavioral health services, financial counseling services, and through our research team. Next slide, please. just a quick overview of what are the core values of Benjamin Rose. And I think that this helps you then to understand the work that we've been doing and how we've responded to COVID. So number one, we are committed to caregivers. We believe that caregivers should not feel hopeless about their situation. We know that we can't make every day beautiful, but we think that we can make every day doable, and that is our goal. We believe the caregiver should not feel alone in managing the needs of their aging loved one. We see ourselves as their partner, helping them to take care of themselves so that they can take care of the people who need them most. And we view the aging process as something worth cherishing. We believe that people can grow old with dignity and respect, and we want to be a part of that process. Next slide, please. So just a quick level set. As we talk about social determinants of health this morning, I wanted to make sure that we're all on the same page as to how we are defining the social determinants of health. This is a term that we're using more and more, and it's really become the language for healthcare providers to communicate in the same way with community-based organizations. So there are lots of different ways of defining them. Some people say there are 5 social determinants, some people say there's 6, some people say they're 12. But what I really like about this graphic is that they all go around and around. It's a circular event. Really, the lines could be crossing every which way, but it's best helpful to think about them as those factors that most impact a person's health that happens outside of the doctor's office. Next slide, please. So on March 13th, we all received, like you, we at Benjamin Rose received the word that we were no longer going to be able to come back into our office. So what happened to us as a direct practice and direct service organization? Needless to say, all of our 7 senior centers in-person operations closed. All of our other in-person services in terms of behavioral health, adult day, senior companion, and other counseling programs were suspended, or they became telehealth or other virtual modes of delivery. All of our new business development efforts crashed to a halt, and everything else pivoted to remote work. So it seems, at least on the surface, as rather bleak times for Benjamin Rose. Next slide, please. But the reality is that we couldn't just shut down because there was a lot of need that still remained. We still had over 600 people on our home delivered meal routes who still needed that daily hot meal. We have over 200 people who were receiving a congregate meal at our senior centers who still needed that meal. We had over 1,000 clients and all the clients served by Benjamin Rose who needed comfort, connection, and they also needed basic supplies like toilet paper and cleaning products. And we have well over 100 family caregivers who still needed direction, validation, and linkages to community resources. Next slide, please. So how did we respond? I think the best way to look at it is to think from the perspective of how do we address the health inequities further exposed by COVID-19? I think we can see a lot of these inequities in some of the basic assumptions that the standard solutions that organizations put out around serving older adults and what they showed us. So many of the solutions assumed that older adults have family supports to help them. They assumed that older adults could navigate the virtual landscape, that with the click of a button, they could go from an in-person visit to an online visit and that they wouldn't skip a beat. Many people believe that older adults, because they've lived so long, are thereby connected to their community. And they believed and based their solutions upon the idea that older adults have access to reliable health information. And I think what COVID has shown to all of us is that these assumptions really are not rooted in fact. Next slide, please. So how did Benjamin Rose approach it? So we really took a deep dive on the social determinants of health that we felt we could best address. So we focused on food insecurity, we focused on social isolation, we focused on access, particularly to services and supplies, and we focused on the caregiver. Next slide, please. So let's start with food insecurity. We believed from day one that we needed to continue to deliver that daily meal to our older adults. So we continued that service. From day one, we continued to push out the number of meals that we committed to. And actually, we've gone from serving about 600 people pre-COVID to almost 1,000 people now on our home delivered meal route, and those people are getting a hot meal every day. We also transitioned our congregate meal recipients to a weekly home delivered meal program, where they are now getting 5 frozen meals a week. So again, getting that 1 meal a day that they were used to receiving. We also collaborated with the Greater Cleveland Food Bank to deliver additional food boxes. So if someone identified as needing more food than they were getting through that 1 meal, if that 1 meal maybe was their only access to food, we then had this collaboration to deliver additional food boxes to them on a twice monthly basis. And we were also lucky enough to partner with MedWorks, who gave us gift cards for restaurant vouchers for our older adults, and even a large delivery of fresh produce that we were able to push out to our home delivered meal recipients. And I think as we go through this, you're going to hear that word partnership and collaboration over and over again. And that really has become our way to serve our community during this difficult time. Next slide, please. So how did Benjamin Rose respond to social isolation? I think the social isolation question is particularly interesting because for us in the social work world, we've talked about social isolation, the impact of social isolation, particularly on older adults, for a long time. And whenever we've talked about it, people sort of roll their eyes at us and wonder, what are we really talking about? Why do you need funding to address that? If people are living in community, they're not isolated. But suddenly, now that so many of us are experiencing social isolation, we're all starting to realize what significant impact it can have on our physical health, our mental health, and our cognitive health. And so our senior center has really tried to figure out how do we adjust, not just adjust our programming, not just how we pivot, but really how do we enhance the offerings that we are putting out of our senior centers. And the longer this has gone on, the more we realize that this is not just a response to COVID. This is really a new way for us to do business and to interface with the older adults who are living in our community. So in terms of what did we do with our senior center programming? Well, one of the challenges, obviously, is access to the internet. Many of our clients are lower income older adults who either don't have the technology, they don't have access to broadband if they even had the technology to use, and many of them don't have the desire or the capacity to learn how to do something different. So we really had to do a lot of creative thinking in terms of how do we remain connected to our older adults. So the one thing that we did was as I said, was to enhance and rethink our programming. So we did bingo games, drive-by parades, and now actually looking to put out what we are calling Rose on the Go programming. It was interesting, at one point in time this summer, we allowed older adults, when we could be outside, to come back to the senior center and interact outside with each other. And the greatest challenge, it was almost like bringing primary school children to the playground for the first time, that no one wanted to stay 6 feet apart because they were so excited to see their friends. They were so desperate to connect that it was really almost virtually impossible to enforce the social distancing that was necessary to keep that outdoor programming a viable option for us. The other thing we did was to establish an extensive telephone wellness and reassurance call program. So previous to COVID, we did not reach out to our home delivered meal clients from the team at Benjamin Rose other than the jumpers and drivers. They know they're jumpers and drivers. The jumpers and drivers are staff members at Benjamin Rose. They drive the same route all the time, and they really do get to know who their clients are. But we didn't have any further involvement with them. But when COVID hit, we realized we really need to understand several things. One, we need to make sure they're okay. Are they safe? Do they have what they need in order to get by day to day? Because we kept telling them, please don't leave your home. We knew that it would be impossible for them to try to navigate how to get that roll of toilet paper or cleaning products that all of us were struggling to who had access to transportation. And we recognized, even most importantly, that they needed somebody to talk to. That one of the things that COVID had taken away from us was that ability to look forward to anything. And so by establishing a regular wellness call program, not only did we check in on them, not only did we make sure that they were connected to someone and they knew that someone cared, but they could look forward to that phone call each week. So that became an important piece of our response to social isolation. The other thing we've done is to work with our clients to use telehealth and virtual services. We've partnered with Access for Seniors, who gave us tablets and smartphones that they could use. And we're working with Connexi to enhance access to broadband as well. But the challenges, of course, still remain. There's still the critical issue of lack of access to technology and to broadband, internet, and Wi-Fi. There's still the major issue of many seniors are still uncomfortable using technology, and they still feel disconnected from friends, programming, and the structure that attending their senior center programming gave to their lives. Next slide, please. We also put on a big push to respond to the basic needs of older adults. One of the key issues that we wanted to tackle was, how do we address access and equity? So one of the things we did was to collaborate with the Cleveland Clinic Center for Geriatric Medicine. This sort of was a launch from partnerships that we had started to develop pre-COVID, but really the partnership exploded. And it gave us the ability, when we were talking with our clients, if anybody expressed any type of medical concern whatsoever, be it COVID related or completely unrelated, they would be guaranteed a call from a Cleveland Clinic geriatrician within 24 hours of reaching out to them. They didn't have to become a Cleveland Clinic patient. They didn't have to be a Cleveland Clinic patient, but it gave them the peace of mind of knowing that they could speak to a doctor about whatever medical question they had by connecting through us. We also piloted tablets with our clients so that they could access the telehealth services. The second thing we did was to really engage with the community in ways that we had never done before. We reached out to schools who had stockpiles of toilet paper and paper towels and said to them, look, now that school's not going back in person, would you donate what you have? We had so many community members sewing thousands of masks that we were able to distribute to our clients. And we also did a huge push for cleaning supplies, something I don't think we ever thought we would be doing as a community-based organization, but it became a huge need for us. How do we get, if we are going to recommend that our clients have access to PPE, we were going to have to help provide that for them. And the last thing we did was we launched a volunteer program. Again, we had people who had volunteered with us, but not in any formalized way. And this now has become a part, again, of how we do business at Benjamin Rose. We used volunteers to help with home delivered meals when drivers had to take time off or were exposed to COVID. We used volunteers to do our wellness caller program. And we used volunteers to actually run the errands. So if an older adult needed groceries picked up, if an older adult needed a prescription picked up, if older adults needed some of the stockpiles that we had that we needed to deliver to them, we had a team of volunteers that would drive to our older adults' homes and deliver those supplies for them. Next slide, please. And lastly, we continued to focus on our caregivers as well as the people who were living with an illness. So you may wonder why the focus on caregivers and why is that so important within a healthcare setting? After all, most of us focus on the person with the illness, but many times we don't recognize how much the health of one person really becomes a family affair, and that the caregiver burden that people live with stresses that caregiver physical and mental health in so many ways. Studies are now showing that caregivers suffer the physical and mental health burdens and stressors of caregiving up to 3 years after the person for whom they're caring has passed away. So it really becomes a critical issue for the healthcare community as well. Moreover, caregivers are the linchpin for compliance with care plans. When we send patients home with a care plan, the person who's going to ensure that the patient does the OT, eats the correct diet, drinks enough liquid, is really that caregiver. And so it is all of our best interest to maintain the health and well-being of the caregiver as well as the person with the illness. Because at the end of the day, keeping that person healthy is how we can minimize high utilization of expensive solutions by both patients and members. Next slide, please. So we wonder, why is it so hard for caregivers to ask for help? And really the question is, why is it so hard for any of us to ask for help? And I think within that caregiver space particularly, there is the assumption of, I should be able to do everything by myself. We feel guilty. We feel like it's part of our role. I am the spouse. I am the child. I am the niece or nephew. I should be able to take care of my loved one without any help. And if I can't, is that a sign that I've actually failed? So that becomes a big piece of why it's so hard for us to get there. The next piece of why it's so hard is that most caregivers are unaware that there are community resources that can help them. For many of them, the first time they've ever had to navigate community resources is when they're dealing with an older loved one, and they simply don't even know how to begin to enter the maze and the web of services that are there for them. And moreover, they're oftentimes stretched thin. Many are working full time, caring for their families of their own. Now they're homeschooling. Suddenly the plan of care for their older loved one has changed, particularly in light of COVID, and they're scared of how much it can cost. So they're stuck in this crazy web of I can do it all, and whatever I do is never enough. Next slide, please. So one of the key responses that Benjamin Rose has to the challenge of family caregivers is our family caregiver support program called WeCare Because You Do. Really what it allows us to do is to take all of the programs and services that are available through Benjamin Rose and also throughout the community, and to help create a wraparound support for that family caregiver, to serve as the hub for all the programs and services that a family needs. So it's not only just about connecting them and serving as the communication hub, but it's really about how do we talk to family caregivers about what's out there? How do we help them navigate all of that? How do we give them, connect them with information that's trustworthy, that they can make good decisions on? Because when you Google on the internet, you have no idea who wrote the information that you're using to make those key decisions. And lastly, we're really about how do we help families communicate with each other? We are very quick to say we can't resolve 30 years of family dysfunction, but we can help to bring families together around the table to talk about how are we going to care for our loved one in this moment. So WeCare then is that one call that families can make to address issues around long-term care planning, financial and legal concerns, housing options, respite possibilities, and to know that they've got a coach that will be there by their side to help them get through these times. So again, we are not care case managers. We don't do the doing, but we make sure that we empower our families so that they have the information to take control of their situation, to feel like they have a plan of care and can move forward. The other nice thing about the program is that people who come into our program stay with us for a while. It's not just a one-time call an 800 number. They're assigned a care consultant, and that person works with the family one-on-one for as long as the family wishes to remain in the program. Next slide, please. So just one more quick piece about WeCare, that family caregiver support program. This is really how we provide solutions for families. Helping them to explore their options, engaging them with local services, helping them to identify what are their must-dos and when can they say no. Helping them to understand that this is their caregiving journey and they don't need to compare themselves with anybody else's. And really reinforcing the idea that self-care is not selfish. Next slide, please. So we took all of those programs that we had, we pivoted them, we enhanced them, and what did we learn from all of this? So the first thing I think that was critical, one of the critical lessons that Benjamin Rose learned through this journey through COVID, and clearly the journey is far from over, but it's about the importance of staying connected to our clients in where they are in that moment. So our wellness caller and volunteer programs have now become a part of how we do business. They are not just simply a response to COVID. The next thing we learned was the necessity to remain relevant. COVID has really forced us to think about how do we reach seniors in our community, not just the old, but also the old and the young old. Because there are a lot of older adults who are looking for programs and services and community connections who may say, oh my gosh, you'll never catch me in the senior center, but they really need to be connected too. Or there are those older adults who are truly homebound, who even if transportation was provided, wouldn't be able to access services. So how do we reach them? And how do we find ways to navigate the connectivity divide, to start to work away at that divide, to try to remove it, and how do we advocate for services for our older adults? The third thing we learned was really the value of partnerships. Leveraging those partnerships enabled us to address unmet needs across a continuum of care in ways that we had never done before. And we now fully realize how important this is for us moving forward. And lastly, and probably most importantly, it reminded us of the imperative of giving voice to the vulnerable. After all, at the end of the day, we are a social service agency, and we must continue to advocate at every level, not just with policymakers, but also with employers and other providers, to have them recognize the needs of our older adults and their family caregivers, and why it's in the best interest of all of us to come together to address their needs. Next slide, please. So it's interesting when we think about our lessons learned to think about what is the work ahead of us. And I think if we take the rollout of the COVID vaccine as a case study, it sheds some interesting light. So we've all heard stories about the vaccine and about how challenging it is to actually get the vaccine. To register for the vaccine really is the most challenging piece. Every day there's more organizations putting out more information, and at one point in time I started to put together a piece for Benjamin Rose, which we actually have on our website, about the policies and procedures for actually getting the vaccine. And it's amazing, I could change that document every day because the information and the processes keep changing. So what have we learned? We've learned at the policy level, we really need to think about how do we address procedures through the eyes of an older adult. It's wonderful to say, just go on my chart and register for your vaccine. But what if I'm an older adult that doesn't know how to use the internet, or I don't even have access to the internet? I don't have my chart. I can't access it that way. If it's about just call until you get an appointment, what if I just don't have the capacity to call for 2 days to actually get on a list? Or I don't even have enough cell phone minutes to make that call. So it behooves all of us to really think through, how do we connect with our older adults so they have access to the services that are supposedly designed to meet their needs, but we actually give them access to it in an equitable fashion, so that no matter how many cell phone minutes I have, or no matter what my connectivity looks like, I can still get that vaccine. At an advocacy level, then, it's imperative for us to push for solutions to address these health inequities. It's also important to think about, what about that caregiver? So if I have a caregiver for an older loved one, if the older loved one gets the vaccine, shouldn't that primary family caregiver have access to it also, if I'm truly concerned about maintaining the health and well-being of that older adult? At the organizational level, it's about, we really realize that need to operationalize the healthcare community-based organization partnership. We could attend weekly webinars on how healthcare organizations can better interface with community-based organizations. But I really think now is the time to heed that call and to say, it's great that we talk about it, but we've really got to make this happen, that it's only with all of us working together that we're going to be able to address the needs of the older adults that are so important to all of us. At an education level, what is our responsibility to consider the barriers to acceptance? What is the history that our older adults bring to this conversation that makes them hesitant to get in that line, to bear their arm and to take that vaccine? And what are we doing as communities to educate them, to alleviate their concerns, and to let them know it's okay to get in that line? And at the service delivery level, at that most basic, how do we solve for the on-the-ground issues around access to transportation, technology, and more? Next step, please. Or next slide, please. So in closing, what are our collective next steps? I firmly believe that we all need to think about, what is our call to action in all of this? So I challenge all of us to think about the following. How do we utilize the social determinants of health as our common language to discuss and resolve the challenges that face all of us? How do we build upon the healthcare community-based organization partnerships which have emerged during COVID to create a new health and wellness paradigm that takes us far beyond COVID and into the future? How do we join forces to address health inequities and to solve for the disparities that are so glaringly obvious in our communities? And how do we design solutions to reach all older adults and not just those who are easy to reach? So I close with one of my favorite quotes from James Baldwin: "Not everything that is faced can be changed, but nothing can be changed until it is faced." Thank you.